Dr. Arun is our speaker for today, and he's done his DM in gastroenterology, and he'll be speaking on the topic. So just to keep time, I'll hand it over to him.
Good afternoon, respected professors and senior friends and colleagues. It's really a great pleasure for me to join in this wonderful occasion. And today the entire discussion being gone in area of cough. And this one eccentric area we are not supposed to forget, which is one of the most common anxiety when you're going to look into your routine practice as a physician, as a surgeon, as a pulmonologist, when you're going to look as without this patient, without this case, our OP are not going to complete. So this is very, very important. You might be thinking a patient who had evidence of chronic cough for which the patient been prescribed with multiple medications and your bronchodilators, your lozenges, your expectorants, your cough suppressant, which will not be worked. But at that point of time, you should not forget that once a patient cough duration is going to prolong for almost of 8 weeks, the chronic cough which will be predisposing to your most common GI entity is none other than your gastroesophageal reflux. As you all remember that the incidence of this gastroesophageal reflux, what do you mean by that? So any contents of your stomach, in case if it is going to reflux it into your food pipe, which is nothing but your esophageal tract, you are going to this gastroesophageal reflux. There are so many reasons are there for this gastroesophageal reflux. And based upon your Montreal's classification, which has been globally well accepted, you are going to take into this discussion. And the incidence of your chronic cough, based upon this gastro, almost around 10 to 15% of the patient being presenting with this kind of event. And as for even then, the other etiological focus like your asthma, your post-nasal drip, that all this anxieties we are not supposed to forget when you are going to manage a presentation like this. And this is a globally accepted definition for your GERD, and based upon your esophageal manifestations or extra esophageal symptoms. I didn't show all those slides, so you should remember that your esophageal presentation will be very common. The two major entity will be your heartburn and your regurgitation. But what is happening for the other extra esophageal presentation will be your cough as well as your dysphonia. These two common extra esophageal typical presentation we are not supposed to forget when you are going to tackle this event. And basics to consider about that, this GERD associated with the trigger of your cough, there are three major mechanisms. One is by your reflux theory and reflux and your esophageal dysmotility. What do you mean by reflux? So in case if you are going to have an acidic reflux or before talking on this area, you should remember about the sphincter mechanism. So there are a basic lower esophageal sphincter pressure if it is not going to get well maintained, and the LES if it is going to get drop out, at that point of time your reflux is going to predispose. There are so many basic physiological processes to maintain this transient lower esophageal sphincter relaxation. And once this pathologic mechanism is going to take on, the reflex theory is nothing but there are two main entities. If your food contents, if it is going to reflux into your esophagus, one is by your acid reflux and another one is by your airway reflux. So the acid reflux there are two major reflexes, as you all know. One is acidic and non-acidic. Acid reflexes will be predisposing to this picture, the food contents being reflexing into your food esophagus, and the airway reflex will be over the time. Once the patient is going to land up with evidence of gaseous mist of your non-acidic composition, which has been gained wide acceptance, which is going to predispose your airway reflex mechanisms. So this is mainly by your reflex theory, and the second one is by reflex. So this is basically a neurogenic stimulation. What is going to happen once your tracheobronchoesophageal reflex, if it is going to get augmented, at that point your vagal is going to get stimulated. So thereby the substance P, the neuromodulator, is going to get triggered off, and the various inflammatory cascade is going to get activated. At that point of time, your trypsin, your histamines, your prostaglandins is going to get released, and which will predispose for your gastroesophageal reflux. Another common important anxiety we are not supposed to forget your dysmotility based disorders. For example, there are a huge list of disorders. See, tackling a gastroesophageal reflux along with cough is not a simple entity because functional dyspepsia, so many other etiological focus are there to concern about this. But esophageal dysmotility, when you're going to look into that, For example, take a consideration for achalasia cardia. At that point of time, what you're going to see, the patient may have worsening of a reflex pathology. The mucous membrane is going to get damaged. At that point, the evidence of your massive reflux is going to get checked on. So, three major mechanisms by reflux, as well as your dysmotility. Briefly to concern about your cough along with your GERD pathophysiology. So, to concern about the risk factors, as we all well know right from the basic knowledge, obesity you need to control. Once you are going to control your obesity, which means you are going to prevent your reflux, which means you are going to control your cough response. So, if the BMI, if it is going to come down for more than 3.5 kg per meter square, at that point of time, your symptoms is going to get improved more than 2 folds in your GERD. Smoking definitely contributing to this, and might be there are some papers to show that when the patient is smoking, at that point the reflux will not be much severe. Once the patient quits smoking, at that point there might be evidence of the reflux to get activated, but still we need more papers to validate. Apart from that, alcoholism is definitely one of the most important trigger for you. Apart from your physical activity, some patients may experience your bending, swimming, cycling, running. At that point of time also you may be having the worsening of your reflux along with all this pathway. To diagnose about this GERD, no single entity is there to diagnose. Basically, you need to look into your clinical presentation, and once your clinical approach, if you are fitting into the criteria of GERD, if you are ruling out all the possible etiological triggers for your chronic cough, at that point of time, there are useless. So when you're going to subject the patient to endoscopy, usually endoscopy indicated for a person whom you are going to suspect evidence of esophagitis. It's, as well as so many grading systems are there. So there are so much of huge modalities are there to diagnose this GERD based upon your questionnaire, based upon your, nowadays even basically we should not forget our ambulatory pH metry along with your impedance monitoring. When you are going to place the electrodes into the esophageal mucosa and the distal esophagus, you are going to assess your reflux as well as your non-acidic reflux content. At that point of time, you are going to look into that. So endoscopy and biopsy, only when you suspect evidence of esophagitis, at that point you can do this endoscopy and biopsy. See, in this picture you can be able to identify based upon the various classifications that there. One simple classification, very important for all the gastroenterologists. So based upon your LA classification, you need to identify how much of erosions is there in the esophagus. Based upon that, we need to categorize. So once the patient is going for this kind of presentation, the cough worsening events may check on at that point of time. So endoscopy and biopsy is not deserved for all these patients. Only when you are suspecting evidence of alarming events, usually at that point of time, you need to go for endoscopic intervention. And when you're going for surgical interventions, when you're going for endoscopic intervention therapy, if the reflux, if the GERD, if it tends to be refractory, at that point of time, you need to go for impedance pH monitoring, in which you are going to place the electrodes, you're going to assess the reflex pathology, what is going to happen, in which there is 2 scoring systems are there. One is D-MIS scoring, it's a 6-parameter component. So what are you going to see based upon your standing position, your supine position, prone position, all those things you need to characterize your reflex. So once, if it is going to be more than 6, at that point of time, your reflux is going to get activated more and more. So we need to maintain our target. Our acid reflux should not go more than 4 once. If it is going to be more than 4, that reflux index which is happening, at that point of time, you need to be very cautious to tackle this kind of presentation. And there are so many other scoring systems out there. These are all not major entities and newer things. What I like to suppose, you should remember that nocturnal impedance in this condition, for assessing a patient who is having nocturnal bursts of your reflux events, this you can use this probe to assess mainly during nocturnal bedtime. As I discussed, your demisters, your post-reflux swallow. So if you're going to take a swallow, the peristalsis, the TLS here, if it is not going to well relax at that point of time, if it is going to be more than 30 seconds, so you are going to see what is going to happen at that point, so assess your reflux. And next to that, your mucosal impedance. See, you cannot measure all the patient to a transnasal catheter. Sometimes directly you can put an endoscopy, and through that you can assess the mucosal impedance when you are going to suspect any evidence of esophageal inflammation or any other pathological event. To this kind of, see why I'm talking on this, you should remember these are all the newer investigations being added on in the armamentarium to diagnose your GERD. And real-time MRI is new addendum to identify if it is based upon your various maneuvers. If you're going to do a Valsalva maneuvers, and at that point of time, you're going to measure your esophageal thickness, and if it is going to be a dynamic variability of more than 20 m a second, so at that point of time, so you can able to identify whether the patient will be having evidence of reflux, and it will guide you for further intervention management. And you can try with the medication of PPI trial. Most of the time it will not respond if it is going to be, your cough may not come down only because of that. So extra esophageal mechanism, the presentation of cough is very difficult to control. Even with your PPI, you should not forget, even with your H2 blockers and all those things. Narrowband imaging is another new innovation to support your diagnosis of add-on esophagitis, any other complications, and salivary pepsin, in which you can able to measure your acid secretion. Apart from that, your basic things, there are huge amount of basic investigations protocol can be carried out based upon the patient's clinical status, reflex pathology, and when you're planning for any interventional surgical procedures, you need to subject whether the patient deserves or not. But one only constraint in India, all the procedures will be very tedious and be very difficult and time consuming. You need to spend more and more time to one patient for this simple entity, in which we are tackling with day in and day out. So you need to choose the patient. Choosing the patient, masterly the criteria, is very, very important. We're not supposed to forget. And briefly, before concluding, we need to remember the treatment protocol. Always the treatment starts with lifestyle modification. But when you're going to do only lifestyle modification, how far it is going to get response? Usually 10 to 20% of the patients will respond. So lifestyle modifications alone will not be enough. So lifestyle frequent small meal and avoidance of junk food, fried food, and high carbohydrate and high lipid based. Apart from that, avoidance of quitting of smoking, alcohol, so many things are there, taking care of your lifestyle. And whenever you are going to sleep, the left lateral will be more preferred rather than the right lateral. There are so many other postural mechanisms to consider for your GERD lifestyle changes, and your physical activity is supposed to get enhanced, but only lifestyle won't be suffice. The next line of management will be your H2 blockers, your PPIs, the new innovation like your potassium competitive blockers. Apart from that, your endoscopic intervention and rarely your surgical intervention. There are so many things are there to consider, but when you're going to subject the PPI, you need to give a patient for a duration of almost around 8 to 12 weeks, whatever the PPI you're going to use, but you should be very cautious. There are many centers being subjecting this PPI for many months to years. At that point of time, the worsening of events is still going to get more happen, because PPI will be not only impair your secretions, it may predispose to multiple complications, as you are well know, starting from your cardiovascular, renal, your major acute coronary, multiple other complications nowadays being case reports are there. So always you need to be cautious to whom you are going to subject a patient with prolonged PPI therapy in the management of your gastroesophageal reflux. Apart from that, H2 blockers can safely be considered, but the problem with H2 blockers is you can consider only up to grade A and B esophagitis. Once the patient is going to land with evidence of grade C and D, at that point the H2 blockers no much of role, and the healing of mucosa is not going to happen sustainably. At that point, but the safe mechanism H2 blockers, when you're combining with your H2, H1, when you're suppressing your cough, H2 blockers will be having a slightly potential role in suppressing along with your H1, but main thing is H2 blockers will not be, will be having evidence of tachyphylaxis, which means the response rate and some basic adverse events that we are well remembered. Apart from that, H2 blockers doesn't yield any major adverse events, papers not been reported much. And the other molecules like your baclofen, which is going to be a GABA agonist, which is going to modulate your lower esophageal sphincter relaxation. So if the patient is having persistent hiccups, other presentations, so you can give, but whenever you are going to put the patient on this kind of model, you need to be very, very cautious. Some neurological events may precipitate. Gabapentin is another thing which will be having similar mechanisms, and newer medications like your vonoprazole and other things, your hydrogen potassium ATPase blockers, the alternative medications, and frequent usage of your alginates preparation nowadays. These are all the things. And prokinetics. Prokinetics can be considered, but to whom you are going to subject, it remains an important thing. But it is going to augment, inhibit your GI motility and your anti-reflux surgery. Now endoscopy has gone very high. Your Straton, other multiple innovation procedures are being happening in the field of gastro to manage a patient who is having persistent GERD, not only based upon your cough of various presentation, or finally the breathing exercise. And before concluding my talk, you should remember that only diet and lifestyle modification will not be suffice, assessing the patient as a whole, diagnosing the patient, and to whom you are going to subject the basic investigations protocol, clinically recognizing the various extra GI manifestations, and with that, we can able to improve the scenario very well. With this, I'm happy to rest my presentation. Thanking you all for patient listening. Any questions from your side?
Thank you, Dr. Arun. That was a nice and concise and quick presentation. I just wanted to ask first of all, is LPRD different from GERD? And if yes, how do you manage it?
Non-erosive reflux is very common anxiety, madam. Most of the anxieties will be a non-erosive because 70 to 80% of the patients, when you're going to subject with the endoscopy, that's, the final slide is, I didn't put that. So if you're going to subject, so most of the time endoscopy will not going to yield anything. At that point, doesn't mean the patient is not having any reflux. So non-erosive reflux scenario will be having a common anxiety, and that NERD will be precipitating your cough and other events. So NERD, if you are going to think about that, based upon your all the studies, and again, the few molecules what are being available along with the diet and lifestyle changes definitely going to give a reasonable response, but making a diagnosis of NERD is still a questionable, a difficult target. See, why I would like to point out, diagnosing a GERD is easy, but tackling a GERD in an effective way is very, very difficult, because once the patient is going to land up with GERD, the psychogenic component will be taking on, because functional heartburn is a component, and the patient will be having functional dyspepsia. Sometimes the patient may be having functional GI disorders like IBS. All these anxieties will be a conglomerating pathology, so you can't diagnose it a simple entity. So assessing the patient as a whole is the most important when you're going to diagnose that.
Yeah, so lots of times it is the ENT surgeons that diagnose LPRD more, and this is a common patient that we have in our clinics who have dysphonia, who have chronic cough, and then the ENT surgeon gives you a diagnosis of LPRD. And in these patients subsets, apparently gabapentin helps better than anything else.
Definitely, gabapentin will be having a potential role at that point of time, because it's not only going to augment, it's going to prevent your palatine reflexes also. This is going to happen.
Any questions? Sure.
Conversely, sir, if a patient has got a GERD, which is resistant to drugs, you test for spirometry, patient has asthma, then unless you treat asthma, GERD is not going to get all right. Isn't it true, sir?
Definitely, sir. The primary pathology has to be controlled. Then only the symptoms will get well controlled. But this is the vicious cycle. If the GERD gets controlled well, your reflex asthma is also going to get controlled, because both the pathways is going to have micro and macro aspiration. So I think my voice is clear. So micro and macro aspiration is going to get happen. So both the areas will be having a same reflex arc. So we need to control your asthma to prevent your GERD, tackle your GERD to prevent your asthma.
And how long, you rightly told, patients get hooked on to the PPAs and prokinetics when you start them giving both asthma medications and GERD. They want to continue GERD PPAs forever. It's a big thing to wean them off. GERD is really tough.
That's
challenge.
what which is happening in most of the centers, Rattu, particularly in government institutions and primary healthcare center. Just like there are patients walking into the casualty, they'll be giving long-term GERD for years. So, I mean, long-term PPA for years. So, which is going to predispose to multiple complications. As we all know, the major acute coronary events is very common paper being reported much time because of your, interstitial nephritis, your funding gland hyperplasia, and rare malignancy is being reported with that, your PPI. So always you should be very cautious and very stringent when you're going to use your PPI. And as said, doctor, we need to advise that better to go with H2 blockers, because H2 blockers is very safe, not only to prevent your reflux, also to inhibit your nocturnal acid breakthrough, because the nocturnal reflux will be more severe once the patient is having multiple comorbidities. So NABs will be very well controlled with your H2 blockers rather than treating alone with your PPIs.
So in that case, can you give PPA in the morning and H2 blockers at night? Can you combine both?
Always. Not my only suspicion. My only suspect, we are not supposed to use dual dose and something else. And I have seen multiple prescriptions who will be giving PPA, one dose of PPA in morning and another PPA in night, which will definitely worsen the clinical scenario of any patient. when you're going to tackle in your routine practice.
Great. Thank you very much, Dr. Arun. I
Thank you
think
very
we'll
much,
close
madam.
this
Thank you.
session.